Pacemaker and ICD Management, Yarmouth Regional Hospital Nursing Education, 2026. This session is about leveling up your pacemaker and ICD game. By the end of this, you should feel confident recognizing what's normal, what's dangerous, and what needs escalation now. We're talking real bedside skills, accurate monitoring, catching malfunctions early, and preventing avoidable deterioration. We'll tighten up pre- and post-op care and sharpen patient teaching because clear education prevents complications like dislodgement, lead pocket infection, and unnecessary anxiety. You'll also hear expert insight from Dr. Saeed, which connects what we see at the bedside with the cardiology perspective. And finally, this isn't just a passive learning. Complete the Pacemaker and ICD competency assessment, and you'll receive your certificate of participation. At its core, cardiac pacing restores adequate heart rate and cardiac output when the heart's intrinsic conduction system fails. When the electrical signals don't move properly from the atria to the ventricles, or the sinus node fires too slowly, patients develop bradycardia, reduced cardiac output, and symptoms like dizziness or syncope. Temporary pacing is used to stabilize the patient. It's a bridge supporting heart rate while we treat the underlying cause or prepare for permanent implantation. Permanent pacing, on the other hand, treats chronic conduction disease. It provides long-term support and prevents dangerous bradycardias. So the big picture is this: temporary pacing stabilizes, permanent pacing sustains, and both exist to maintain adequate cardiac output and protect perfusion. There are 4 main types of cardiac pacing we need to understand. First, transcutaneous pacing. This is external pacing using defib pads. It's fast and life-saving, uncomfortable, typically used as a temporary bridge in emergencies. Transvenous pacing. A pacing wire is inserted through the central vein into the right ventricle and connected to an external pacing box. This provides more reliable temporary pacing while awaiting permanent implantation or recovery. This is well known to Yarmouth ICU. Third, epicardial pacing. Common after cardiac surgery, temporary wires are placed directly on the epicardial surface and exit through the chest wall, also connected to an external generator. And finally, permanent pacemakers. These are implanted devices with leads positioned in the heart's chambers to treat chronic conduction diseases. The key difference is duration and stability. So transcutaneous and transvenous are temporary. Permanent pacemakers provide long-term rhythm management. So temporary pacing stabilizes patients when the causes may be reversible, like drug effects, ischemia, or post-op conduction changes. Permanent pacing treats chronic conduction diseases such as sick sinus syndrome or persistent AV blocks. So think temporary is a bridge, permanent is long-term therapy. This slide helps us decode pacemaker modes. So we don't have to memorize them, we just have to think through them logically. So remember, the first letter tells us what chamber is paced. The second tells you what chamber is sensed. The third letter tells you how the device is responding, so either triggered, inhibited, or dual. So if we take common examples, DDD, that means it paces both chambers, senses both chambers, and can either trigger or inhibit based on what it detects. This allows the device to maintain AV synchrony while responding appropriately to intrinsic activity. Once you understand that structure, you can decode any pacemaker mode systematically instead of memorizing. So now, in contrast, most temporary transvenous pacemakers are programmed VV1, ventricular demand pacing. So VV1 means the ventricle is paced, the ventricle is sensed, and pacing is inhibited if intrinsic ventricular activity is detected. So this one's simple, it's reliable, it's stable hemodynamic, it's appropriate for bradycardia, high-grade AV blocks. That's your VV1. So understanding the mode helps us predict how the device should behave at the bedside. We're going back to the basics. A permanent pacemaker is a small, battery-powered device implanted under the skin to maintain a safe and regular heart rhythm. It treats bradyarrhythmias and AV blocks when the heart's natural conduction system fails. This system includes a generator, 1 to 3 leads that deliver electrical impulses to the heart muscle. The battery life typically lasts 7 to 15 years, and a generator replacement is usually a minor procedure. The key point is a pacemaker supports cardiac output by preventing dangerously slow heart rates. Types of pacemakers. The single chamber pacemaker uses one lead, typically in the right ventricle, sometimes the right atrium. It often used for chronic AFib with slow ventricular response or isolated AV block. A dual chamber pacemaker uses 2 leads, one in the right atrium and one in the right ventricle, allowing coordination between the upper and lower chambers to maintain AV synchrony. A biventricular pacemaker, also called cardiac resynchronization therapy pacemaker, CRTP, uses 3 leads to stimulate both the ventricles simultaneously. This improves ventricular synchrony and is primarily used in patients with heart failure and reduced ejection fraction. There is also a closely related device, a CRTD. This is the same resynchronization system, but it includes a built-in implantable cardioverter defibrillator. That means it not only improves ventricular synchrony, but can also detect and treat life-threatening ventricular arrhythmias with anti-tachycardia pacing or shocks. And then finally, a leadless pacemaker is a small, self-contained device placed directly in the right ventricle via a catheter, so eliminating traditional leads. So understanding the device type helps predict ECG patterns and following up of potential complications. Good day. I'm here with Dr. Saeed, who supports the Pacemaker Program Clinic along with Dr. Shahal here at Yarmouth Regional. Thank you so much for being here, Dr. Saeed. Tell us what type of devices are currently being planted at Yarmouth.
We are implanting a single chamber and dual chamber pacemaker for patients. Also, we are implanting implantable loop recorder for monitoring, long time monitoring, and we are planning to implant ICD defibrillator in the future.
Good day. I'm here with Dr. Saeed, who supports. Pacemakers have evolved from bulky external devices in the 1950s to highly sophisticated, reliable systems used worldwide today. So, millions have been implanted with proven improvements in the quality of life, reduced morbidity, and improved survival. So, early milestones included external pacing, then percutaneous endocardial pacing, and eventually the first permanent systems. Modern devices are small, durable, fully programmable, and capable of remote monitoring. So, pacemaker therapy has become safe, refined, and life changing for patients with conduction diseases. Let's take a moment to review the core components of a pacemaker system. First, the pulse generator. This is the battery and circuitry, essentially the brain of the device. It contains the power source and the programming that determines how and when pacing occurs. Second, the leads. These are insulated wires placed inside the heart chambers. They both deliver electrical impulses to stimulate depolarization and transmit intrinsic electrical activity back to the generator. The sensing system detects intrinsic beats, allowing the pacemaker to inhibit pacing when the heart is functioning appropriately. The pacing function delivers impulses when the intrinsic rate falls below the programmed threshold. So simply, the generator decides, the lead delivers and reports, and together they maintain adequate heart rate and cardiac output. This image shows a typical implanted pacemaker system. The generator is placed subcutaneously, usually below the clavicle. The incision is made in the upper chest, and the generator sits in a small pocket beneath the skin. From the generator, leads travel through a central vein, typically subclavian or cephalic vein, into the heart chambers. In a dual chamber system, one lead is positioned in the right atrium and the other in the right ventricle. The atrial lead helps coordinate atrial activity, while the ventricular lead ensures appropriate ventricular contraction. The lead tips are secured into the myocardium, either with passive ties or active fixation screws. Understanding this anatomy helps explain complications. Arm movements can affect lead stability. Subclavian access can lead to pneumothorax. Generator and pocket issues can lead to a hematoma or infection. So having a visualization of this system will help us more logically understand what's going on. This chest X-ray shows a permanent pacemaker in the left upper chest with leads traveling through the venous system into the heart. So on review, we confirm three things: correct lead positioning, stable generator placement, and no immediate complications like a pneumothorax. The ventricular lead should track toward the right ventricular apex, and an atrial lead, if present, curves into the right atrium. Knowing what normal pacement looks like allows us to quickly recognize displacement, migration, or post-procedure complications. This slide outlines our key preoperative nursing responsibilities before pacemaker implantation. First, clinical preparation. We confirmed informed consent, reviewed indications such as why they're getting it, sick sinus syndrome, AV block, symptomatic bradycardia. We ensure IV access is established, labs are reviewed, CBC, lights, and an INR if the patient is anticoagulated. A baseline EKG, rhythm assessment, clearly document the allergies, especially iodine, adhesives, anesthetics. Second, patient teaching. We prepare the patient for what to expect. The procedure typically takes 60 to 90 minutes, performed under local anesthesia with sedation. Leads are inserted via a vein and the generator is placed subcutaneously. We also set expectations about immediate post-arm restrictions and wound care. Providing Nova Scotia Health pamphlets, patient pamphlets, reinforces education and supports safe recovery after discharge. Below we have living with your pacemaker. It's also in French. Living with your implantable cardioverter defibrillator, and then a cardiovascular device implant. This pamphlet lists a 6.1 cardiac day unit, but it could be used generically for Dr. Saeed. What matters most immediately after pacemaker implantation? First, monitoring. Patient remains on continuous cardiac monitoring. We're watching closely for loss of capture, failure to sense, or any new arrhythmias. Vital signs are monitored. We assess hemodynamics, inspect the incision for bleeding or pocket hematoma. We want to keep the dressing dry, clean, protected. Second, arm restrictions. The first 2 weeks are critical to prevent lead dislodgement. So no reaching above the shoulder level, no lifting more than 5 pounds. So it's about a 2-liter milk jug. No pushing or pulling with the affected arm. Slings used to be ordered, but we encourage people to gently use their arm rather than not move it at all. Third complication, third thing we're looking out for is complications or surveillance. Hiccups can indicate ventricular lead migration. Dizziness may signal pacing malfunction. Right-sided chest pain or dyspnea raises concern for pneumothorax. Swelling, drainage, or fever suggest infection. And finally, diagnostics. Every patient requires a post-implant chest X-ray and a formal device interrogation to confirm lead positioning and function. Post-op care. Last week you installed 2 pacers at Yarmouth Hospital.
Mm-hmm.
One of the patient was ordered vitals every 2 hours and the other every 3 hours.
Mm-hmm.
Is this patient dependent, or do you have a standard vital monitoring preference post-op pacemaker insertion?
Mm-hmm. For patients who are on the extreme part of the blood pressure, for example, low blood pressure or high blood pressure, I prefer to do the monitoring every 2 hours. But for a stable patient, I prefer to just 3 hours will be enough. But the other thing is sometimes during the procedure, I'm concerning about something happening in the procedure, then I prefer to do it more frequently. For example, 2 hours every 2 hours, and this is the situation dependent. I mean the procedural and also patient hemodynamic.
Thank you. Post-op care. Last week. What's normal and what's not after a pacemaker implant? This is taken from the AACN Procedure Manual for High Acuity Progressive and Critical Care. So expected. The pacemaker works as programmed. We see appropriate sensing and capture. Electrical capture equals mechanical capture. So we want to confirm that every spike should get a pulse. The patient looks better, is alert, perfusing, normotensive. So dizziness, syncope, shortness of breath, these symptoms should be improving. Some incision soreness is normal. The site should be clean, dry, no swelling, no drainage. Unexpected outcomes, failure to sense, failure to capture, especially early on, think lead dislodgement. New hemodynamic instability, distant heart sounds, intermittent capture issues. We're worrying about perforation. Abdominal twitching could be diaphragmatic stimulation. We want to watch for hematoma, infection, or arm swelling, suggesting a thrombus. So, bottom line, a pacemaker should improve stability. If the patient is looking worse or something's wrong, let's assess and escalate. Mild swelling and bruising are expected in the first few days, especially if the patient is on antiplatelet or anticoagulation therapy. However, the site should not be rapidly expanding, tense, or extremely painful, which would raise concerns for a pocket hematoma. The dressing should remain clean, dry, and intact. Patients should avoid showering until cleared by the implanting team. Reinforce them not to remove the stereo strips or manipulate the incision. We want to monitor carefully for signs of infection, redness spreading beyond the incision, increasing drainage, warmth, foul odor. Any drainage or skin breakdown over the pocket requires urgent assessment. Early detection of a hematoma or infection prevents progression to device erosion or full system infection. This slide highlights when a temporary pressure dressing may be indicated after a pacemaker implantation. So pressure dressings are typically used when there is a concern for pocket bleeding or hematoma formation, especially in patients on antiplatelet or anticoagulant therapy. The goal is gentle, consistent compression over the generator pocket to reduce bleeding and prevent expansion of a hematoma. Devices like the safeguard system, a structured shoulder band compression, or a structured shoulder band compression dressing may be used. So, as nurses, we must monitor closely for excessive tightness. The dressing should not impair circulation, restrict breathing, or cause skin breakdown. We also reassess frequently for increased swelling, firmness, or discoloration beneath. Pressure dressings are temporary measures. Persistent or expanding hematomas require physician assessment. Skin erosion is a serious late complication of pacemaker implantation and is most often the result of a pocket infection. However, other contributing factors may be present, especially in the elderly patients with fragile skin, minimal subcutaneous fat, or chronic corticosteroid use. A pocket that is too small, excessive tension, or even abrasive disinfectants can also increase risk. Erosion typically develops gradually and is rarely an early complication. Once the generator or lead becomes exposed, it is considered contaminated. Exteriorization equals bacterial colonialization until proven otherwise. So at that point, complete system removal is mandatory, followed by antibiotic therapy, and eventually reimplantation on the contralateral side once the infection is cleared. So nursing priority is early detection, identifying skin thinning, delayed healing, discoloration, or breakdown before hardware becomes exposed. Most pacemaker implants are safe and uncomplicated. These are the highest risk complications in the first 6 weeks post-implant, and this is our vigilance window. So first, pneumothorax, typically related to subclavian access. Think new dyspnea, pleuritic chest pain, oxygen drop, or unexplained hypotension. Any respiratory symptoms post-implant warrants a chest x-ray. Second, pocket hematoma, the most common early complication, around 5%. Risk increases with dual antiplatelet therapy or low molecular weight heparin. A tense hematoma is not benign. It increases infection risk and can lead to skin necrosis and erosion. Third, lead displacement. This occurs in up to 10%, and we want to watch for syncope, dizziness, hiccups, loss of capture or undersensing. Early arm movement is a common trigger. Fourth, myocardial perforation or pericardial effusion, chest pain, dyspnea, hypotension. Always consider a tamponade in an unstable patient. And finally, pocket infection or skin erosion often follows a hematoma or re-intervention. Exposed hardware equals infected system until proven otherwise and requires full removal plus antibiotics. So early detection is a nursing responsibility and subtle changes matter. What is the standard follow-up schedule for patients?
It depends on the patient being inpatient or outpatient. In inpatient people who receive pacemaker, I sign up after implanting the pacemaker, and it depends on the background disease. Maybe it takes few days after implantation of the pacemaker to be discharged, and after discharge I can see the patient here in 10 to 14 days to follow up with the uh, pacemaker site, uh, healing process, and the dressing situation. And this is the same for outpatient, but in for outpatient this time is um, definitely between 10 or 14 days, but for inpatient, because they spend some days in hospital, could be shorter.
Okay, thank you. What is the standard?
I follow up my patient here in my clinic with this equipment as you are showing the programmer for both um, companies, the Abbott company, Medtronic company. We have the equipment here, the programmer, this one for Abbott, and this is a new programmer for Medtronic. Then we have enough to be able to follow patient in our clinic. I follow up my patient here in my clinic. For people who are living with pacemaker and defibrillator, they have a plenty of the question, including about driving, including about post procedure, taking care of the wound, about taking shower, bath, and antibiotic, sign of the infection, limitation of the activity, limitation of the arm movement, and these are very good to know and explain for the people, because sometimes we don't have any good communication with the people and they do some mistake, and this is not good. For people who are living.
Can you tell us about EMI?
Yes, this is a very common question from the patient. They are asking about touching some electronic device like a TV, microwave, especially, and touching the remote control using the mobile phone. This was very concerning in the past, because the sensitivity of the devices was very low. Then the electromagnetic equipment can interfere with the pacemaker. But nowadays this is resolved, and there is no, because there's a precise sensitivity of the pacemaker, they don't sense outside signals. Then the pacemaker is very safe. There is no limitation to use any of these devices except for MRI.
Can you tell us about EMI?
Yes, this is in case of the MRI, we prefer to make some changes in the pacemaker setting, then they can go for MRI. Then after that, we can reset it for the default setting. But in case of the emergency, they can go for MRI, and after MRI, we can do the changes or we can evaluate what happened for the pacemaker. But fortunately, all of our devices today are MR sensitive.
MRI sensitive?
MRI sensitive.
Okay.
Then it means there is no damage possibility to the pacemaker with the MRI, or very small, very tiny percentage of the pacemaker could be affected by this MRI. But as you know, the MRI today are 1.5 or 3 Tesla. Maybe for higher dosage of higher power of the MRI, would be more concerning.
So MRIs can be safe
Can
if
be
the person
safe.
has come to see you and you have manipulated the settings.
Yes,
Okay,
it is better way to safer way, but in emergency cases, they can go for MRI, and after MRI, we can do the same thing.
But the MRI won't stop
No,
the pacer.
no, doesn't stop. In case of the MRI,
we teach patients to report immediately any syncope or near fainting that could indicate the loss of capture or device malfunction. Dizziness, new palpitations, sudden fatigue, chest pain, shortness of breath. These may signal pacing failure, pneumothorax, or pericardial complications. Persistent hiccups can indicate ventricular lead irritation or displacement. Redness, swelling, drainage, or fever raise concerns for pocket infection. Twitching near the device or unusual vibration or beeping may indicate device alerts or inappropriate stimulation. So, we are monitoring for signs of inadequate cardiac output, lead complications, or infection. Clear education prevents delayed presentation and reduced morbidity.
we had some patient who received a shock. They had their ICD defibrillator from Halifax, and we have a system. It send the alarm for Halifax Center, and they call the patient to come to closest center. And in some cases, we were the closest center. The patient came to us. We evaluated here to be what's happening on the patient. Is it dangerous? Is it a real shock, or it is something factious or something like this? Then we can manage it here. Sometimes we can manage. Sometimes we have to just prepare the patient to transfer to the Halifax to do some changes on the device. We had some patients. We have a province-wide website. We call it PaceR, and every patient information is there. And we have access for all patient information. They have access as well. Then, in general, yes, they are connected to the QET cardiology. Then, for example, if the patient go for some reason to Halifax, Kentville, Bridgewater, Sydney, it is possible to make a interrogation. It's possible to find all information about the pacemaker and the last interrogation information. For example, if I found one patient has a problem in one of the leads, then they can find it there.
Nice. Sounds like a good communication
Yes,
system.
good communication. And sometimes people have a procedure in Halifax that like a procedure we couldn't do this here. For example, ablation or valve replacement, TAVI. Then we refer to them and they refer to us to follow up. Okay. We have these are the equipment, we call it them programmer. When patient is here, we can use these devices to bring the pacemaker information inside our screen, and we can see what is happening for the patient, the rhythm. Sometimes normally they have a good parameters in the pacemaker, but sometimes we can find some abnormality in the rhythm, abnormality in the function of the pacemaker, and more importantly, we can measure the longevity of the pacemaker. Longevity means uh, how how much left in the patient in the pacemaker life. Then
Is that the magnet you put over it?
yes, this is related to this machine, to this programmer, and we put this one on the pacemaker, on the patient skin, and it transfers the data from the pacemaker to the system. We can see this.
And that one?
There is nothing invasive here. Everything is communicatable by WAN or even without WAN with a Bluetooth system. These are the equipment we call it.
Many patients feel anxious after a pacemaker or ICD is implanted. They may worry about dependence, fragility, or future shocks. It's important to reassure them that these devices are durable and designed to prevent dangerous bradycardias, dangerous arrhythmias, and to protect cardiac output. Most patients return to normal life expectancy and independence. We encourage a gradual return to exercise once cleared. Activity builds confidence and supports heart health. For ICD patients, anxiety about shocks is real. Acknowledging it, normalize it, and offer support when needed. Also reinforce that generator replacement when the battery runs low is typically a minor procedure. So the key message we want to share with our patients is the device is there to protect them, not limit them. When assessing pacemaker function on the cardiac monitor, keep it simple. Look, are there pacing spikes when expected? Second, is there a capture? Every spike should be followed by a QRS. So spikes without a QRS equal failure to capture. Third, is it sensing properly? The pacemaker should inhibit when intrinsic beats are not present. So if not, you may see inappropriate firing or pauses. And finally, we're going to watch for irregular timing or long pauses. At the bedside, remember, pace, capture, sense. If any of those fail, escalate immediately. So there are 3 core pacemaker malfunctions to recognize: failure to pace, no pacing spikes when the heart rate drops below the set rate; failure to capture, spikes are present, but no QRS follows. The pacemaker fires, but the myocardium doesn't respond. Failure to sense, the pacemaker doesn't recognize intrinsic beats and fires at the wrong time. So at the bedside, remember, no spike, failure to pace. Spike without a QRS, failure to capture. Spike at the wrong time, failure to sense. So rapid recognition helps prevent instability. We're going to dig into these a little deeper. Failure to pace means a pace stimulus is not generated when it should be. So on the monitor, you're going to see decreased or absent spikes. You can see there, especially when the heart rate falls below the programmed rate. So the most common cause of this is oversensing. The pacemaker mistakenly interprets non-cardiac signals such as skeletal muscle activity or external interference as intrinsic heartbeats. As a result, it inhibits pacing. Other causes could be lead fractures, insulation defects, battery depletion, or program issues. Clinically, patients may present with dizziness, bradycardia, hypertension, or even syncope. The key nursing action is to treat as unstable. We're going to assess the patient, place on the monitor, notify cardiology, apply external pads if indicated, prepare for rescue pacing. The bottom line, if pacing spikes are absent when they should be present, we're going to escalate immediately. Failure to capture occurs when the pacemaker delivers a pacing spike, but the myocardium does not depolarize. So on telemetry, you're going to see a pacing spike without a QRS complex. So this means the device is firing, but the heart is not responding. Common causes could include lead displacement, wire fracture, rising pacing thresholds from inflammation or ischemia at the lead tip. Electrolyte disturbances like hyperkalemia could contribute. Clinically, patients are going to develop bradycardia, dizziness, hypertension, syncope, especially if they are pacemaker dependent. Nursing priorities: assess the patient, confirm electrical capture on telemetry, and mechanical capture by checking a pulse. Notify cardiology. We're going to apply external pacing pads and prepare for rescue pacing if needed. So, key takeaway for failure to capture: spike without QRS equals failure to capture, and that requires immediate escalation. Failure to sense. This happens when the pacemaker does not detect the patient's intrinsic cardiac activity. On telemetry, you'll see the pacing spikes at inappropriate times, sometimes falling within or immediately after a QRS complex. This results in asynchronous pacing. So it's concerning because if a spike lands during that vulnerable part of the T wave, it can trigger ventricular arrhythmias, so the classic R on T phenomena. Common causes include early lead displacement, incorrect sensitivity settings, lead fracture, or electromagnetic interference. Clinically, patients may report dizziness, palpitations, bradycardia. Nursing priorities are immediate assessment, continuous monitoring, urgent notification to cardiology. We're going to apply pacing pads if the patient is unstable. So, key reminder for failure to sense: spike at the wrong time equals failure to sense, and it needs prompt escalation. Can you talk to me about the use of a magnet in a
Mhm.
clinical setting? What is that used for? In ICU, we have many type
Magnet.
of magnets
Mhm.
ready and available.
Mhm. When you use the magnet for pacemaker, it is different from when you use it for defibrillator. When you use the magnet for pacemaker, in case of the, uh, for example, your patient is going for operating room to, to be done on the surgery, and you are concerning about the cutter noise or cutter signals interference with the pacemaker. Sometimes the cutter is very close to the pacemaker, and pacemaker sense it and thinks this is hard, then inhibit. Pacemaker stops. Then in case of the in some patients who are dependent on the pacemaker completely, it is dangerous because the pacemaker thinks, oh, this is hard, then I have to stop and let the heart works. But this is not the heart, this is noise, this is a signal from the cautery. Then it is dangerous. For resolving this problem, we put a magnet on that, then the pacemaker just works, doesn't sense anything from the outside. It works, it doesn't care about the heart or signals from outside, then it will be very safe. Okay. This is the magnet for pacemaker. Magnet for ICDs just stops or turn off the therapy function. Then during the, for example, operating room, you don't want to receive any shock by ICD, then you can use the magnet during the operation. Can you talk to me about the use of a magnet? A magnet is a temporary tool, not a permanent solution. For ICDs, placing a magnet turns shock off but keeps pacing on. It does not turn off the heart, erase programming, or permanently deactivate the device. Magnet effects are temporary and reversible, so once removed, shock therapy resumes unless the device is formally reprogrammed. Use a magnet only when indicated, such as repeated inappropriate shocks, and always confirm device type first. You would apply it. How we would do it is we'd apply it directly over the generator, secure it. We're going to monitor and document thoroughly. Key reminder: magnets for temporary suppression, not long-term management. Okay, we are going to talk through 7 case scenarios. I encourage you to press pause in between each scenario when I ask the question and try to come up with some answers, and then we'll
I'll go through the answers or likely information. So, case scenario 1. A patient is post-op day 1 following permanent pacemaker insertion. Telemetry shows heart rate 42, visible pacing spikes, but no QRS complexes following spikes. What complication is this? What are immediate nursing actions and priorities? Case scenario 1. This telemetry shows pacing spikes without QRS complexes. So this is failure to capture, and this is abnormal. So on post-op day 1, the most common cause is early lead displacement or rising pacing thresholds from local myocardial inflammation. So the fresh lead may have shifted slightly due to arm movement, coughing, or repositioning. Other contributors include low output settings or electrolyte abnormalities like hyperkalemia. But on day 1, think mechanical first. Nursing priorities. Assess the patient immediately. You're going to look for dizziness, hypotension, syncope, signs of poor perfusion. Place on continuous monitor. Notify cardiology. We're going to apply external pads in case temporary pacing is required. Restrict arm movement. Keep the patient NPO in anticipation of possible lead revision. We're going to check the electrolytes and correct reversible causes. So key takeaway from case 1, spikes without QRS, failure to capture, treat as unstable, and early actions prevent syncope or asystole. Case scenario 2, patient post-op day 1 to 3 after permanent pacemaker insertion. They report, I reached overhead to grab something. Now I have persistent hiccups. Telemetry shows intermittent pacing, so inconsistent capture and sensing. What is happening? What are immediate nursing actions and priorities? This case scenario 2, is most consistent with early lead displacement. So the key trigger is overhead reaching within the first few days after implantation. In the first 1 to 2 weeks, leads have not yet scarred into place. So reaching overhead can pull the lead from its fixation site or create slack, causing unstable myocardial contact. Now, the patient has persistent hiccups. That's a major red flag. If the ventricular lead migrates, it can stimulate the phrenic nerve or diaphragm, producing the rhythmic hiccups or abdominal twitching. The telemetry shows intermittent capture, so sometimes the QRS, sometimes a pacing spike with a QRS, sometimes without. So this is inconsistently, and that strongly suggests lead instability. Nursing priorities. Assess for dizziness, syncope, hemodynamic stability, review telemetry, review the monitor, notify cardiology, place on monitoring, and restrict arm movement immediately. We're going to apply external pads, and if symptomatic or pacemaker dependent. So key teaching points: hiccups after pacemaker insertion equal lead displacement until proven otherwise. Case scenario 3. A patient with a recent implanted permanent pacemaker. He's keeping their cell phone in their shirt pocket directly over the pacemaker site. They report experiencing a sudden buzzing sensation in the chest, feeling lightheaded at the same time. The telemetry shows intermittent pacing irregularities that resolve when the phone is moved away. What complication is this? What are immediate nursing actions and priorities? Case scenario number 3 is highly suggested of electromagnetic interference, or EMI, affecting pacemaker function. The key clue is symptoms and pacing irregularities resolve when the phone is moved away. Modern pacemakers are shielded, but when a phone is placed directly over the generator pocket, especially with Bluetooth or Wi-Fi or magnetic components, the device may misinterpret that signal as an intrinsic cardiac activity. So this leads to oversensing. In-demand modes like VVI or DDD, oversensing can cause the pacemaker to temporarily inhibit pacing because it falsely believes the heart is beating on its own. The patient then experiences a buzzing or a fluttering sensation, irregular beats, lightheadedness. If pacing pauses, the heart may go back to its underlying rhythm, which could not be good. Nursing priorities. First, remove the source of EMI. Ensure the phone is kept at least 6 inches away, ideally carried in a pants pocket or a bag, never over the pacemaker site. Assess and monitor, check vital signs, symptoms, confirm rhythm normalizes upon removing the source. We're going to review the telemetry, look for pacing inhibition, noise, artifact, or mistimed spikes. We're going to be vigilant with our monitoring. And fourth, educate and document. We need to teach the patient. No phones in shirt pockets, throw over the devices, use the opposite ear, keep devices 6 to 12 inches away. If symptoms persist after removing the phone, we're going to escalate immediately as a possible device malfunction. So EMI can cause pacing inhibition, especially dangerous in pacemaker-dependent patients, but is often reversible with a simple, rapid nursing intervention. Take it away. Case scenario 4. A 61-year-old male received dual chamber pacemaker for a sick sinus syndrome. He was discharged home after an uncomplicated post-op course. 1 week later, he returns to the ED with right-sided chest pain, progressive dyspnea, mild anxiety, and discomfort with deep inspiration. Think on what complication is this? What are the immediate nursing actions and priorities? Case scenario 4 presentation should immediately raise the concern of a delayed pneumothorax. So 1 week after pacemaker implantation, this patient develops right-sided chest pain, progressive dyspnea. So even though the pneumothorax usually occurs immediately after subclavian access, delayed cases are documented. Are well documented. The key physical finding is absent breath sounds on the right. Additional signs may include tachypnea, hypoxia, hyperresonance. If severe hypotension, tracheal deviation suggests tension pneumothorax, that's a medical emergency. So important, the ECG may look completely normal for a pace rhythm. So a normal paced ECG does not rule out a pneumothorax. Nursing priorities, notify the physician, apply O2, a continuous monitoring, prepare for urgent chest x-ray, anticipate a chest tube insertion if a pneumo is confirmed. Teaching point, any post-pacemaker patient with new dyspnea or unilateral breath sound changes require an immediate x-ray, chest x-ray, and early recognition can help prevent deterioration to a tension pneumothorax. Case scenario 5, 2 more to go. 80-year-old male, dual chamber pacemaker for complete AV block. He is on ASA and Plavix for a prior stent. He had a large pocket hematoma post-implant and was treated conservatively. 3 months later, persistent non-healing wounds, skin necrosis, and visible leads. So think, what early complication triggered this chain of event? What risk factors are present, and what is our major concern now? So case scenario 5 illustrates how an early complication can evolve into a serious device infection. We've got an 80-year-old male with dual chamber pacemaker, for a complete AV block. He was on dual antiplatelet therapy for so shortly after he developed a hematoma. 3 months later, and it was treated conservatively, that hematoma. 3 months later, he is having early complications triggered this chain of event was the pocket hematoma. So the hematoma increased pressure in the pocket, compromised blood flow to the already fragile geriatric tissue. So that's significantly increasing infection risk. Risk factors present: advanced age, dual antiplatelet therapy, and the decision not to evacuate the hematoma, or perhaps even prevent the hematoma if we had a pressure bag. So this is no longer just a delayed wound. Visible leads mean exposed hardware. Exposed hardware equal contamination until proven otherwise. So this is a pacemaker pocket infection requiring full system removal, generator and leads. This is not a dressing problem, it's a surgical problem. So we want to monitor hematomas closely, escalate early if the healing is delayed. And remember, once the hardware is exposed, the system is considered infected. Case scenario 6. 68-year-old male post-dual chamber pacemaker placed 1 month ago for recurrent syncope due to carotid sinus hypersensitivity. He lives alone, reports mild anxiety, doesn't really have good understanding of why he had it, didn't get good education. He later confesses to playing with or adjusting his pacemaker under the skin. So the device interrogation shows no P wave, no R wave, no atrial or ventricular caption, impedance abnormalities. The battery is otherwise normal. And the chest x-ray reveals both leads displaced from expected anatomical position, leads wrapped around the generator in the pocket, and the generator also appears rotated and retracted from the original placement. So let's think on what complication is this? What risk factors can you identify in this scenario? And how can you help prevent this? Case scenario 6 represents Twiddler syndrome. This is a behavioral complication where the patient rotates the pacemaker in the pocket, causing the leads to coil and retract. When this happens, the leads can lose contact with the myocardium, so that explains the interrogation findings. This isn't a program issue, it's a mechanical lead displacement. The chest x-ray confirms that leads displaced, coiled around the generator rotated. This is dangerous, especially in pacemaker-dependent patients. They can develop severe bradycardia, asystole, and collapse. Risk factors here include anxiety, lack of understanding, so we didn't have proper education, and manipulation of device. So as nurses, we need to know prevention is key, clear teaching. Do not twist or manipulate the pacemaker. We want to flag patients who are frequently touching the site, ensure we follow up with this. Twiddler syndrome is preventable, and early recognition protects patients from serious harm. Last case scenario. 79-year-old male with an ICD for ischemic cardiomyopathy and prior ventricular tachycardia. He's now admitted for end-stage heart failure with refractory symptoms despite maximal therapy. Goals of care meeting confirm the patient is comfort focused. C2, do not resuscitate. Over the past 24 hours, the patient experienced increased dyspnea, episodes of chest discomfort, 2 ICD shocks triggered by non-sustained VT, significant emotional distress after each shock. So the ICD shock contradicts the comfort focused plan of care, causing pain and anxiety. And the family says, he can't keep getting shocked like this. He just wants to be comfortable. What interventions can be done to promote patient comfort and dignity? This last case highlights the importance often misunderstood in the interventions in end-of-life cardiac care. This patient has an ICD and is now comfort-focused with DNR orders. Despite that, he continues to receive painful ICD shocks. These shocks are no longer aligned with his goals of care. As ICU nurses and as OR nurses, we need to understand that a magnet can temporarily disable ICD shock therapy without affecting bradycardia pacing. So let's be clear, a magnet does not turn the heart off. It does not stop pacing. It only suspends tachytherapy, meaning shocks and anti-tachycardia pacing. So with the patient consent and the physician confirmation, a clinical magnet is placed directly over the ICD generator. Immediately, the shock therapy is deactivated. Bradycardia pacing continues. The patient stops receiving painful shocks. Comfort measures continue uninterrupted. The provider provides immediate relief when formal device reprogramming is not immediately available. So in this case, the outcome is what we want. The patient becomes calmer, more comfortable, able to rest, and no further shocks occur. A plan then is made for permanent ICD deactivation by the device team the following day, which would be consistent with its goals of care. So magnet plus ICD, shocks off, pacing on. Magnet does not stop. It only suspends tachycardia therapy. So we want clear communication to explain it to the family and to the patient what the magnet does and does not do. And we want to document these communications. In summary, pacemakers significantly improve patient safety by preventing dangerous bradycardias, arrhythmias, and support cardiac output. But the device itself is only part of the safety system. PACU and ICU nurses play a critical role in the first hours and days after implantation. We are the ones continuously monitoring rhythm, hemodynamics, capturing, sensing, and incisional status. Early detection of abnormalities, whether it's failure to capture, oversensing, lead displacement, or pocket complications, can prevent escalation, re-intervention, and patient harm. Recognizing subtle changes early is what protects our patient. So technology supports the heart, but nursing vigilance protects the patient. This is a list of references for this material, and I invite you to participate in the competency assessment to apply for your certificate of participation. Thank you.